So today I'm going to talk about land use and land cover change and malaria risk in the Amazon region. Before I really talk about this theme, I want to give some background of why I decided to tackle this problem. So here I am 10 years ago. I didn't cut this tree, I'm not responsible for it. But nevertheless, I had just finished my undergrad in forestry. Then I worked for 3 years in a research NGO. I went to do a master's in forestry at the University of Florida. And during that time, I was working with sustainable timber yields in the Amazon region. And so I was able to get some papers published. I interacted with policymakers. But it eventually became evident to me that it was awkward to spend so much time and energy and money, in the case of policymakers, on something, if you realize that perhaps 98% of timber logging in the Amazon region is illegal. So you can draft these very nice laws, but nevertheless, it really, in reality, doesn't matter, because since so much is illegal, then you're not really changing anything at all. So during my PhD, I thought I would pursue something that people really would stop and give more attention to. And that's why I decided to tackle the theme of land use and land cover. I'll just abbreviate as LULC, and malaria. And so the main question in this talk is trying to figure out if there is a relationship between these two, and if there is, what sort of relationship. So just a very brief description of malaria. Malaria is a disease, infectious disease transmitted by mosquito. Because the vector, the mosquito, is known to be influenced by microclimate, it's very sensitive to that. It seems to be a logical connection that perhaps by altering microclimate and perhaps drainage conditions through land use, land cover, that could affect the vector and therefore the risk of being infected with malaria. So here's a bit of the literature on that. So there was a recent review saying that 42% of the burden of malaria can be attributed to the environment. And so that's a large fraction. But also, if we think historically of the different countries that used to have malaria, it's kind of interesting. Many countries that actually you don't currently think of having malaria used to have it. So that includes England, Portugal, Spain, and here what I'm showing is a picture from CDC of the US. And so all the region that's dark in 1882 is the region that used to have malaria, and there's a picture 1932. And if you look at the earlier papers, what they say that was going on here was basically there was massive ecological change through people cutting down forests and replacing savannas by agricultural fields that often had very poor drainage, and that resulted in a lot of malaria. But then you see this very large shrinkage of the area with malaria in 1932, and then it makes you wonder, well, how was the US able to go from here to there? And usually people attribute that to the drainage of the land, but there was also a lot of vegetation management, and you can think of that also as in terms of controlling the amount of vegetation around the mosquito breeding sites. And interestingly, as you probably know, history repeats itself, and we can see kind of a similar pattern going on currently in the Amazon region. So here's a picture, a time series of you can think of malaria cases divided by total population. So that's the annual parasite rate for the Brazilian Amazon. And in the 60s or 70s, they started the construction of this highway called Trans-Amazon. And basically the idea there was that there was a military government in Brazil thinking that there was this vast region full of resources and that very few people living there, and that all these foreign countries interested in that region would be very easy for them to invade and occupy. So their idea was either we occupy it ourselves or we surrender the region. That was kind of the mentality at that time. And at the same time, there was a lot of landless people in the northeast. And so it made perfect sense for them. Well, we have this area that we have a lot of land but few people. We have this other group of people that don't have land and they want land, so let's just put them together. So they stimulated the human settlement in the region by paving roads, giving out lands. And what you saw at that time was not only a huge increase in malaria cases, but also a huge amount of deforestation. And so if you just look at the literature from the Brazil, you would see that people really link a lot of ecological disturbance to malaria. And so in a way, that's kind of repeating the agricultural frontier expansion in the US is now to some extent going on in the Brazilian Amazon as well. And so the question is, well, there seems to be a lot of relationship of land use, land cover with malaria, but the goal of this presentation is really to get a closer look at that and see how exactly that relationship is. Here, just talking a bit about the Amazon region, why would we focus at that region in particular? So it is a region that's very sensitive. There's a lot of pressure currently. So here's a map of a recent study showing in red the areas that had been deforested from I think 2000 to 2005. That region there is called the arc of deforestation. So this region is really important in terms of biodiversity. You can think of carbon stocks, regulates regional climate. A lot of the drinkable water in the world goes through that basin. Nevertheless, it's under a lot of pressure. One thing that, on the other hand, people that work with conservation don't know is that this region is also critical in terms of public health. So here are some indicators of public health for the region. So the Brazilian Amazon has less than 1 physician per 1,000 inhabitants. Does somebody know what's the corresponding statistics for the US? Any guess? Just to put into perspective, right?
6 per 100.
6 per 100. Very off. It's 2.4. But for the for Brazil in general, it's 1.8. So there are not many physicians down there. This really has a very high child and maternal mortality rate. You can see this time series. This is the Brazilian Amazon. This is Brazil, and this is maternal mortality. It's around 60. For the U.S., it's around 21. So it's a lot smaller in the U.S. But I think for this talk, one of the things I find most interesting is that almost all fatalities in the Americas related to malaria are concentrated in the Amazon region. And from the entire country of Brazil, 99% of the cases are in the Amazon region. So it's this map showing in heat colors the areas that have higher malaria incidence. And I think that's kind of the interesting thing, because then you can kind of compare with the map up there, and would there be any relationship between the areas that are being deforested and malaria incidence? So because of this importance of this region, there have been large-scale conservation projects initiated and currently ongoing to try to reduce deforestation in the area. So there was this the world's largest forest conservation initiative, and also the Brazilian government has stated repeatedly its intent of reducing deforestation. So there's that official commitment to reduce deforestation by 80%. But also, because of its public health importance, there are other large projects aimed at reducing malaria in the region. So here you have the USAID project, the Amazon Malaria Initiative, and also the other project from Global Fund to fight tuberculosis, AIDS, and malaria. And the interesting thing is that these projects have largely been implemented in parallel. There's no really conversation going on, and you might wonder, could perhaps results from one project benefit another project, or could they actually be conflicting in some way? And so the key question here is, are we in a situation where perhaps conservation and public health can benefit each other. And if so, that would be really a great news for public policies makers, because in that case, then there's a lot of synergies. Perhaps these projects could work together, and in that sense, you would waste less money if it was done so, and you would have a much more important, a much more relevant public policy message if there was this win-win situation. On the other hand, you could have a situation where actually more conservation means less public health, or vice versa, where there's a trade-off, in which case there's all sorts of ethical issues that might arise, especially because public health burden is typically very local, while conservation benefits such as ecosystem services are typically regional to global. So there are all sorts of interesting questions that might arise if there is indeed a trade-off between these two. So today I'm going to start by giving a description of a study that I conducted in a place called Ramal Granada, Acre. This is the picture of Brazil. In blue we have the Brazilian Amazon, and here's the study site. So Acre is the state here on the southwestern Brazilian Amazon. Here's the Landsat mosaic of 2006. In green are areas that are forested, in pink are areas that are deforested, and here's the sites that I'll be talking about. As you can see, this region of the state is highly deforested. The capital is around here, Rio Branco. But the state overall is pretty much conserved. So zooming into this area, basically, this is a depiction of the study site. In green are the places that are the blocks of forests. Black here you have the roads. So, and in red, the red dots are the individuals that were sampled for malaria. On total, there were 480 individuals. And so this is a rural settlement area. And a nice thing of this study, so basically the way this study initiated was basically I teamed up with Brazilian epidemiologists that were working in this area. And the interesting thing is that there's a natural gradient of forest if you go from the primary road to the end of the secondary roads. And that's basically because as settlers arrive, they typically want to be close to the primary road, and then the ones that arrive later, they get further and further away. And so often this area has a lot more deforestation simply because people have been there for longer, while up there's not that much deforestation at all. So there's a natural gradient, which is particularly nice for this study to really tease out and evaluate if this gradient has an effect on malaria risk or not. Just to say that this area has been still undergoing a lot of deforestation. So all the polygons in red over there are areas that were deforested between 2004 and 2007. The other thing I want to emphasize in this picture is just to keep in mind the scale that we're working. We're working in 20-kilometer more or less scale, and this will become important when we go to the second study that I'll be talking about that will be a much larger spatial scale. So, as I mentioned, the epidemiologists with whom I was working with, they had done these 4 cross-sectional surveys in that region. Basically, they go in, they enlist everybody that wants to participate in this study, and they sample the individual at 4 different times, regardless of if they're feeling symptoms or not. And that will be important, and I'll stress it later on in this presentation. And they also use PCR, polymerase chain reaction, and microscopy too. So they take a blood sample, and then you got to figure out if the plasmodium, the agent that causes malaria, is in there or not. And you can use a molecular technique, the PCR, or basically microscopy. So they had collected this data. When I went in 2010, I collect a different data set. Basically, I went to the health posts and tried to get the records for the same individuals that were sampled up there. I wanted to get their records to see when and how many times they were sampled for malaria, and what were the results. Now, the tricky thing of this type of data is that it's just microscopy. So microscopy is the standard of the Brazilian surveillance system. They don't have PCR applied to the entire system. And microscopy is cheaper, but it's actually less sensitive, so it's not as good as a method as PCR. And the other tricky thing with this data is that, as you can imagine, people don't go to health facilities just because they have on their schedule. They're feeling sick. And so it's hard to make inference on the prevalence for the entire population if all you have is data from people that felt sick. And so we had a number of challenges. And what researchers typically do when they have this type of data, they say, well, let's ignore the government surveillance data. We know it's biased. Microscopy is not all that great. Perhaps we'll just use the cross-sectional surveys, and let's stick with the best method, the PCR. And then we can do all our analysis based on that. And my intention was to try to integrate these data sets with the idea that perhaps there would be a lot of information here. It was just a matter of knowing how to do that properly. And so these were the modeling challenges. We had to integrate the different case detection methods. So the government surveillance data just having people that are feeling sick, the cross-sectional surveys sampling everybody regardless of symptoms, different pathogen detection methods. Both I wanted to use microscopy and PCR within the same model. They have different sensitivities, specificities. And I also wanted to make inference on two things rather than one. So I here stands for the infection status, and S stands for the symptom status. So I wanted to make inference on what were the factors that influence the chance of the person being infected, but also what were the factors that influence the person having symptoms given that the person was infected. And so that's a bit harder to do with standard methods like logistic regression, so we built our own model to do all these three things. So I'm not really going to go into the details of the model, but just to say that I'll just report the results. But part of the overall novelty of this was also in the modeling approach. So here are some of the findings. Basically, on this axis we have forest extent as a fraction of the area in which each person lived. So as forest extent increases, the chance that you're infected increases. So these are these lines. There is a significant interaction with precipitation. So if you live close to forest and it's raining a lot, you have a higher chance than if it's not raining. The other thing that was also kind of interesting was to look at some forest-related activities. So here we have extractivism, hunting and fishing, and here's kind of the three things: being a man and participating in these extractivist activities and hunting and fishing. So just to show that being engaged in these forest-related activities actually, at least based on our model, increase the chance of being infected. On the other hand, one of the key variables that we wanted to test, and that was often cited in the literature as a primary factor related to malaria risk, was deforestation. But deforestation actually never came out to be significant in these models. So some of the things that we can do with these results is, for instance, to make a map of infection prevalence for the entire region. The green polygon over there is the study area, and we extrapolated. And what you can see in this figure, besides the road network, you can see there's a river that crosses diagonally the site, and so there's a high infection risk close to that river, but also in large blocks of forests here, 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 you can see a predicted higher risk of acquiring malaria. And the other thing that was also interesting from this study was that we were able to calculate the probability of being an asymptomatic carrier. So asymptomatic carriers are those individuals that are infected, but they don't show the symptoms. And this is kind of a tricky population to sample because they never go to the health facility because they feel perfectly well. And nevertheless, they can continue transmitting the disease. And so typically when you're thinking about eradicating malaria, it's important for you to figure out, well, how can you figure out who these individuals are? And so based on the modeling results, what we see is that people that live in areas with a lot of forest, so basically in this side of the plot, and they are actually relatively new to the region, so that's Time and Afrilandia, are the ones that are more likely to be the asymptomatic carriers. And that result has a lot of public health implications, I thought, and nobody really had looked at that yet. So, and the nice thing of being able, this is the rationale for trying to model both symptoms and infection status simultaneously, is to try to draw an inference on who these asymptomatic carriers are. You can only do that if you integrate these two outcomes. So one of the things that I found most interesting, but I never got to publish, is this result. So the researchers, when I went there, they used to be working here from 2004 to 2007, but then they moved. They went to way over there. And the reason for doing that was that there was no malaria case on the region that they were working previously. And if you just look at all those green polygons which represent the forest cover, it's kind of interesting to see that, well, perhaps this area had a lot of deforestation. There has a very high forest cover and high malaria risk as well. So all these seem really to suggest that being close to forests, regardless if you're deforesting or not, actually increases your risk of being infected. So these were the main results from the case study that we did. And now we're going to move to a much larger spatial scale. And before doing so, I would like to know if you guys have any questions regarding this study, just because we're going to move on to another one. And for those that arrived late, there's actually food and drinks back there. Yeah.
Can you go back a slide? I guess it's more of a medical question maybe, but is there a reason why those who may be new to an area aren't showing symptoms? I guess my general thought would be that if they've been in an area longer, they may have some sort of acquired immunity where they're not showing symptoms but may carry the parasites.
Right. So the modeling results showed two things. One is that if you're living longer in the region, you have You have a smaller chance of being infected. So there is some sort of acquired immunity. As you see, usually people used to think of, in many African countries, malaria incidence actually decreases with age because you have been exposed to a lot more malaria, and then you have some sort of acquired immunity. But this also happens in other regions of the world, and that's what we found here. But the other thing that we found was that if you were infected, you have a higher chance of showing symptoms if you were living longer in the region. So it almost seemed like that you are only being infected by the most virulent strains. So if that virulent strain is able to infect you, then you're more likely to show symptoms. Something along those lines. So before drawing this plot, it wasn't clear how these different things played out because they were really going to opposite directions. But it turns out that actually people that are newer to the region, they are less likely to show symptoms and to be infected.
So Dennis, is what you're saying that it's for this calculation, it's the total number of carriers is decreasing because of immunity, and that's the reason you're actually getting this increase or decrease in asymptomatic, just simply asymptomatic carriers. If you said what's the probability of carriers that are asymptomatic, that wouldn't necessarily be decreasing with time. What
I'm saying with this figure is that So if we went into the region right now, and we sampled, say, people that had been there for quite a long time and lived in highly deforested area, versus sampling somebody that was in a highly forested area and was new to the region, there would be a higher chance of this guy being a asymptomatic carrier rather than this guy.
That's what I thought you were saying.
Yeah.
But the fraction of carriers that are asymptomatic might not be.
Right. That might be different.
Hey Dennis, just out of curiosity, anecdotally, do you have information, or does the region have information, are you seeing like a replacement of dengue as you have more higher population? I'm not really sure what the population statistics are here, but you know, as you move to, if it becomes more urban, if you can call it that, or just higher population density, do you know if they're seeing a higher rise?
I haven't.
Dengue there?
I don't actually have dengue statistics for this region, but I haven't seen anybody commenting. And one thing is that this region is actually, I mean, although it's heavily deforested, it's very far from what you can think of urban. So I don't necessarily know that dengue is a major issue there.
Oh yeah, yeah.
But it's an interesting question. So I never got to publish this, but I thought really this result was really interesting. And talking to the epidemiologists, they never agreed with saying, well, areas with high forest cover actually imply higher malaria risk. But if you just look at the patterns of where they went and so on, it seems suggestive. So now we are going to go from 20 kilometers to 1,300 kilometers. So this picture over there is the Brazilian Amazon. Each gray polygon is a different county. The black polygons are the different states. So this data is quite interesting, quite rich. Everything comes from the Brazilian government surveillance data. It's 4 years and a half, approximately, 2004 to 2008. Covers a huge area and a huge number of malaria cases, 2.5 million malaria cases. Now, despite being so rich and having so much data, it is really tricky to model this because there are a number of issues. One of them, and we can go into more details, one of them is knowing where the health facilities are within this large area. So for you to have an idea, I think this is the largest county. It represents like 12% of England, but 0.1% of the population. So it's a huge area, it's very small population. So if you don't know where the health facilities are, you can say, well, this county is largely forested, so these people must be living within the forest, and we can contrast that against malaria. But it actually might be totally the opposite. It might be that they live in a highly deforested region, but it's because population density is so low, it might be just surrounding them, and the county overall is very forested. So there are a number of challenges into modeling this. I won't go into details, but just keep in mind that it's not trivial. So the first thing is we can just look at the data and see what it tells us. Here, what I'm doing, I basically divided the data set into 10 population size classes. The idea was I wanted to control for population size class, so I would hope that within each population size class, I can compare in more or less the same units the counties within each bean. And what I did, I actually classified, I made half of the counties that had high forest cover. I assigned them to the high forest cover category. They are in green. And the other half was assigned to the low forest cover, and they're in white. And so we can make this pairwise comparison within each bin. And it's quite striking to see that without doing necessarily any modeling, just the counties that have high forest cover, they typically have higher malaria incidence. So malaria incidence here is number of malaria cases per month per county, when compared to the counties that have low forest cover. And that seems to be somewhat consistent across the different population size classes. Now we can try to do something similar with deforestation rate, which has kind of again being cited as the main culprit for malaria in the region. And you don't really see that evident of a trend there. I mean, sometimes malaria cases are higher in one category, sometimes in another. So I thought just by plotting this result, it was really interesting to see these things stand out. Now, on the other hand, these types of graphs are not without their problems, because there may, perhaps these areas that have high forest cover, they might have a number of other characteristics that could also influence malaria, not only forest cover itself. One of the key things that people raised when they were reviewing these articles was saying that perhaps these counties with high forest cover, they're also poorer, so that people that live in these areas, they live in more precarious conditions, which makes it easier for the mosquito to come in, there's less drainage, and so perhaps there's a confounding issue here with poverty. If that was the case, what we would expect would be the following. Say this was GDP, we would expect that everything in green would have very little GDP, everything in white would have high GDP, if poverty was really an explanation for what we are finding here. When we do go and make that plot of GDP against population size plots, we see that that's not necessarily true. Counties that have high forest cover are not necessarily poorer than the ones that don't have high forest cover. So that rules out one thing, but there could be a number of other things. So we can still keep on going with this visualization exercise by plotting data differently. This time I'm plotting malaria incidence per person. So it's kind of standardizing by dividing by population size. And you can see kind of this nice increase with forest cover. Not necessarily nice for the people that live. Still, it seems really evident from this plot. While for deforestation rate, it's a bit messier trend, if any, there. So again, it's going back to the idea, well, could it be just the fact that you're close to the forest rather than necessarily being engaged in deforestation be the main reason behind having malaria? So what do these results imply for conservation? One of kind of the main interventions that conservationists have thought of in the tropics to halt deforestation is to create protected areas. And protected areas, therefore, have been created in many different places. In Brazil in particular, I think a lot of the expansion of the protected areas network in the world has been in the Brazilian Amazon, partly because of those statistics related to deforestation rate. So we can try to see, well, could perhaps areas close to protected areas have higher malaria incidence? Maybe that's a reasonable thing to ask if we think that indeed forest cover is related to malaria incidence. And we see somewhat of an interesting pattern that on the different beans, the areas that are close to protected areas tend to have higher malaria incidence. And that kind of repeats itself. And so when people are saying about creating protected areas, it might be important to consider side effects, for instance, on public health. Now we took this one step further and trying to do some futurology. Here we're going to try to predict what's going to happen to malaria till 2050. And to do that, we rely on two things. First, we fitted a statistical model to our data. This statistical model related the number of malaria cases with deforestation rate, forest cover. There were also some climate covariates, and there were some random effects to control for other things that we weren't specifying in the model. And the other thing that we had in our hands that was really neat was this land use, land cover simulation model, where in 2006 there were these researchers that published a paper in Nature where they created this model and they tried to predict what would happen to the forests in the Amazon region through time. And they did so for two scenarios. One scenario was called a governance scenario, and the other one was called business as usual scenario. business as usual basically consisted on continuing the paving of the roads that were planned and were ongoing at that time. The protected areas would be mainly paper protected areas in the sense that deforestation could occur within them, up to I think 40%. That was one of their assumptions. Law enforcement would be low, so a number of other restrictions on deforestation would not be put into place. That was their business as usual. The government scenario was, well, we have these protected areas, we are going to be able to protect them very well. Deforestation is not going to happen within them. Many of the roads are slated for paving, they are not going to be paved, and we'll be able to control overall what's going on in the region. That was the governance scenario. We can use the simulation model results as input for our statistical model to then predict what would happen in terms of malaria. So we rely on this quantity. So C is the number of malaria cases for site I, year Y, under the governance scenario, divided by the number of malaria cases under the business as usual scenario. So ratios that are bigger than 1 mean that perhaps by decreasing deforestation, avoiding deforestation, we have higher malaria cases number relative to the business as usual. Ratios smaller than 1 mean the opposite. And what we see here, the projections, is that while we start in a mixed situation where there is part of the counties actually have this ratio being smaller than 1 and part have higher than 1, as we go into the future with more and more prevented deforestation, shown as this green polygon in the back, we go into these heat colors, basically showing that this ratio really tends to be greater than 1 as we prevent more deforestation. And still playing around with this idea, if we're going to summarize information across space, kind of take an average for each year over all of these counties, what we see is the following. We see this trend. So in green, what I'm showing is the prevented deforestation. So, and here's time. So we are able to prevent approximately 10% of the deforestation by 2050 if we are in the governance scenario versus the business as usual scenario. On the other hand, this ratio of malaria cases under the governance versus business as usual scenario also increases, and it's almost like a parallel to this green line, and increases up to 2 point something, and so it almost doubles. And so those are really interesting patterns that suggest that these conservation actions can have or may have important implications for malaria. And so here are some of the implications. So one of the things that people are stressing a lot in the region refers to RED, which is reduced emissions from deforestation and forest degradation. And usually when you think about, well, how much does a 1 ton of carbon that we avoid emitting cost, people usually think, well, if we are not taking the forest out, then we are actually impeding agricultural production. So they usually think that the opportunity cost of that 1 ton is related to the production of agriculture. But the results that I just showed actually suggest that there's more to that story than just agricultural production. There might be some costs related to public health for the people that live in the region if you are to preserve the forest. The other thing is that, again, as I showed in the beginning, you have these large, massive projects going on both in the conservation and global health arena, but they don't necessarily talk to each other. It might be the case that they should, and so what I'm saying over there is that basically there needs to be more coordination between conservationists, conservation scientists, epidemiologists, to really understand these different trade-offs that can occur. And also, if you think about ministries, typically ministries are ministries of health, ministries of environment, and each one work within their silo, but actually there needs to be a bit more integration there. One final note here, this talk is not about so let's deforest everything and that will be better for all. But it's just to say that there are many trade-offs that could exist, and if you don't know about them in advance, some decisions that you can make might be not the optimal. And so indeed these ecosystems are really important for a number of reasons, but then it's also important to acknowledge that they may have a number of other impacts if you keep them, and how really to decrease malaria toll while keeping this ecosystem is kind of the key question. And the first thing is really to identify where these trade-offs could exist. So with that, I'm ending. These were 2 chapters of my PhD thesis. There are other 2, but I think I wouldn't have time to present. So this is what I brought to you guys today. Thank you.